Good morning, ladies and gentlemen. My name is Meera Sivasodi, and I will be taking you through today's program. And it is indeed a great pleasure to have you as our guest for this event titled Kidney Health for All, with supporting partners the National Transplantation Resource Centre and the Malaysian Society of Transplantation. Let me just go through and introduce our VIPs and our guests, and welcome to all of you, members of the media. Our panelists and speakers today are three very esteemed individuals. Please welcome Dr. Rosnawati Yahya. She's a consultant nephrologist, head of the transplantation unit at the Department of Nephrology, Hospital Kuala Lumpur. She also is the president of the Malaysian Society of Transplantation. Joining us also Associate Professor Dr. Lim Soo Koon. He's a consultant nephrologist and head of the Renal Division, Department of Medicine, University of Malaya. And Dr. Hasdy Haron. He's a senior clinical organ donation manager at the National Transplant Resource Centre. Just a quick introduction to Kidney Health for All. Now, our panel doctors will share information on the prevalence and treatment options for kidney disease and organ transplantation. The reason we feel this is actually important is because about 5% of our population are not aware that they actually have chronic kidney disease. And a study in 2018 shows us that about 15.5% of the Malaysian population has a kidney disease, whether or not it ranges from stages 1 to 5. So we'll get a lowdown on what these stages are, and also to find out a little bit more about what are treatment options and support that is available. Firstly, if I can ask you to give yourself a name followed by your organization on Zoom so that it is easier for us to know who's actually speaking. And after which there will be a panel discussion in which you can include your question in the chat box, and we will address them during that session at the end. So without wasting any more time, let's get into exploring the prevalence of chronic kidney disease in Malaysia. Please welcome Dr. Rosnawati Yahya, consultant nephrologist, head of the transplantation unit, Department of Nephrology, Hospital Kuala Lumpur, and president of the Malaysian Society of Transplantation, to share her insights on chronic kidney disease. Dr. Rosnawati.
Thank you very much, Meera, for that kind introduction. Good morning, ladies and gentlemen. Let me share my slides. Okay. I would like to give an overview what is chronic kidney disease is all about. Okay, basically, chronic kidney disease is a long-term condition where the kidneys don't work as well as they should. And it is a common condition, often associated with aging. There are several stages of chronic kidney disease, as mentioned by Meera earlier, from stage 1 to stage 5. And basically, you started off with stage 1 and you progress over the years. At stage 1, your kidney function is still very good at above 90% of your total kidney function. And subsequently, it can progress to stage 2, where the kidney function dropped to about 60 to 89, progress further to stage 3A, stage 3B, stage 4, and stage 5. And the rate of progression differs from one person to another. Some progress slowly, some progress faster. And the rate of progression is very much depends on many factors, such as the control of your blood pressure, control of your sugar if you're a diabetic, whether you take a lot of salt, and if someone smokes, they tend to progress faster than non-smoker. And obesity is also another risk factors to progress to end-stage kidney disease. At stage 5, or also known as end-stage kidney failure, there are a few options of kidney replacement therapy, which is a topic that Professor Lim Soo Koon will take on further. So what is the current state of chronic kidney disease in Malaysia? First, I would like to share a publication by Dr. Saminathan and his co-worker who published this paper a few years ago looking at the prevalence of chronic kidney disease. As you can see here, this is a comparison between CKD study between 2011 and 2018. As you can see, CKD is on the rise and continue to be a major public health problem in Malaysia. The prevalence had increased from 9.07% in 2011 to 15.5% in 2018. What is even more alarming is that only 5% of patients are aware that they actually suffer from CKD, and the rest actually do not know they have CKD, because this study was done by screening the public, our public. Okay, sharing. This is basically a slide that comes from the 26th report of the Malaysian Dialysis and Transplant Registry 2018. The one on the left is the incidence, which are the number of new cases reported every year. In 2018, there were 8,500 new treated end-stage renal disease patients. Our registry captured those who are being treated for end-stage kidney disease. So those who actually refuse dialysis actually are not captured in our registry. So the number could have been bigger than 8,500 as mentioned. The graph on the right is the prevalence or the total number of patients who are being treated in that particular year. So in 2018, there were almost 46,000 patients being treated for end-stage kidney disease. And what type of treatment do these patients receive? Majority were on hemodialysis, which is the blue bar. About 20% were on peritoneal dialysis, which is the red bar, and only 6% received a kidney transplant. And this is actually just to share with you on the economic burden of managing end-stage renal disease to the Malaysian healthcare system. In 2016, the public sector spent $785 million or 4.2% of the total health expenditure, and this has increased by 94% compared to the year 2010. And you can see only 6% of the end-stage renal disease expenditure was spent on kidney transplantation, whereas the other 94% were actually spent on dialysis. And what is even more worrying is that the number of end-stage renal disease is expected to increase from 46,000 in 2018 to 100 to 120,000 in 2040. And the number is projected to significantly increase in the future, predominantly due to the increasing prevalence of diabetes and hypertension. And this is data from the National Health and Morbidity Survey 2019. 1 in 5 Malaysians adults suffer from diabetes, and that is about 3.9 million adults in Malaysia. And we can see that the prevalence of diabetes had increased significantly from 11.2% in 2011, 13.4% in 2015, and 18.3% in 2019. And 40 to 50% of people of our adult population are not even aware that they actually have diabetes. And how about hypertension? 30% or 6.4 million people in Malaysia are hypertensive. Only 50% are aware that they have the disease. 90% of those aware are on medication, and those who are on medications, less than half of their blood pressure actually are under good control. As we know, uncontrolled blood pressure is one of the most important risk factors to progress from early stages CKD to end-stage renal disease. The other alarming issues is obesity. As I mentioned earlier, obesity is a risk factor to progress to more severe stages of CKD, as well as a risk factor to develop diabetes and hypertension. And the prevalence of obesity in Malaysia had increased from 17.7 in 2015 to almost 20% in 2019. So what are the other risk factors to develop CKD? This include elderly, I mentioned obesity, patient with cardiovascular disease, patient with family history of CKD, patients with gout, those with kidney stone and prostatic disease, those who ingest painkillers on a regular basis, and those patients who suffer from autoimmune diseases and glomerular inflammation. So what are the efforts made to educate the public on chronic kidney disease? Okay, various efforts had been undertaken, led by the Ministry of Health and various professional societies, including Malaysian Society of Nephrology, Malaysian Society of Transplantation, as well as National Kidney Foundation, among others, to raise awareness about our amazing kidneys. We highlight that diabetes and high blood pressure are key risk factors for chronic kidney disease, and we encourage systematic screening of all patients with diabetes and hypertension for chronic kidney disease. We emphasized preventive behaviors, and these include eat healthily, low salt diet, regular exercise, a regular check on sugar and blood pressure, and if the person is already diagnosed to have diabetes, they need to ensure good blood pressure control, and those with hypertension must get their blood pressure under control and to stop smoking. Not only that, we also focus on educate all medical professionals about their key role in detecting and reducing the risk of CKD, particularly in the high-risk populations. We encourage transplantation as a best outcome option for kidney failure, and we also emphasize on the act of organ donation as a life-saving initiative. This is a slide that comes from the World Kidney Day. Every year we celebrate World Kidney Day. World Kidney Day is a global campaign aimed at raising awareness of the importance of our kidneys. World Kidney Day is celebrated on the second Thursday of March every year. And this year, World Kidney Day falls on the 10th of March 2022 with the theme of Kidney Health for All, Bridge the Gap to Better Kidney Care. This is my concluding slide. CKD prevalence is rising with big impact on the healthcare system. We need to identify the risk factors for CKD progression. We need to screen those at risk accordingly. We also need to improve on patients' health risk literacy and understanding of their condition. And finally, improve healthcare worker knowledge and communication with the patient. With that, I thank you for your kind attention.
Thank you very much, Dr. Rosnawati. So while we look at the alternatives to dialysis, which is the most common form of treatment for chronic kidney disease, the advancements of science and practices in nephrology have given the opportunity for doctors to recommend several treatment options to chronic kidney disease based on their best needs. So organ transplantation is one of the optimal options to chronic kidney disease, believe it or not, because in our minds, the perception has always been that it is dialysis. So to know more on organ transplantation, I would like to welcome Dr. Hasdy Haron, Senior Clinical Organ Donation Manager of the National Transplant Resource Centre, better known as the NTRC, which is based at Hospital Kuala Lumpur, to share with us the types of organ transplantation, eligibility aftercare regime for donors, as well as recipients. Over to you, Dr. Hasdy.
Thank you, Mira. I hope everyone can hear me.
Loud and clearly. Go ahead, Dr. Hasdy.
Thank you very much. As I supposed to be the last speaker, but I can still proceed the presentation. So I will cover on the option for CKD treatment, more specifically of organ donation and transplantation. Next slide. In my outline presentation, I will talk on the kidney donation and transplantation, the type of kidney donor and also type of transplant. And I will speak on a bit on the policy statement regarding organ transplantation in Malaysia. And we will go a bit touch on the living and as well as a deceased transplant. And what is the challenges that we face in our country nowadays to improve the transplant, and what is the effort and strategy that we have doing all this time. Okay, thanks. Next. Okay, the key policy statement regarding organ donation and transplant in Malaysia, this is according to the National Transplant Policy by the Ministry of Health. Organ procure or organ retrieved from the deceased donor are more preferred to the living donation. However, where appropriate, organs from living donor actually may be used and considered. And National Transplant Procurement Management, which is my office, NTRC, shall be established to coordinate deceased organ donation in the whole country. And the third key policy regarding transplant, organ transplant shall be promoted as the preferred treatment for end-stage organ failure because this is cost-effective and it provides good quality of life. As you can see from Dr. Rosnawati's presentation, the burden cost for kidney disease is huge. All right, next. Okay, speaking of the kidney donation and transplantation, we have two types of donation and transplant. First, we have the living related and unrelated living donation and transplantation. And then we have also donation and transplant from a deceased donor. And this deceased organ donor can be divided more into two types, which is donation after a brain dead patient and of course, donation after a cardiac death donor. Where in our country, in Malaysia, the deceased organ donor are used mostly from brain dead patient. Next. Okay, when we talk about living donation and transplantation, this is where a donation or transplant coming from a living person who donates an organ, and in kidney donation is one kidney lah, and a part of organ for the liver donation, and this is for the purpose of transplant. So this type of donor we can divide into whether this donor are related to the recipient. We call the related living transplant. This is consists of family members, either first degree family members or second degree family members, and to some situation that we can consider up to the third degree family members. And there is also donor who is not related at all with the recipient, what we call is unrelated transplant, which could be a friends, acquaintance of friends, and in our policy, a foreigner donor, although they may be actually related, but in our policy statement, they still are put into the unrelated transplant. So this unrelated transplant must require a special authorization from our committee, our Ministry of Health committee. This is what we call a UTAC committee, Unrelated Transplant Approval Committee. And unrelated transplant shall be considered if one, there is no deceased donor. Later on, we will see the statistic, which is proof that our deceased donor is very, very low. Okay, and number two, there is no compatible in related family members after they actually explore the possibility of transplant between the family members, but there is no compatibility. It could be many reasons for that. And of course, the number three, and there is no alternative treatment for this patient and the patient in urgent needs of transplant. Okay, next. And the benefit of living donation, they have more shorter waiting time. A patient with kidney failure usually wait for several years to receive deceased donor. And in our situation in Malaysia, deceased donor are not so many, not so huge. So, and however, with a suitable living donor, such transplant can be done within weeks. So, and number two, living donation is elective surgery because living transplant is a surgery where you can plan, you can prepare your patient between the donor and recipient, and it can be done at the best help for the surgery. So, living donor transplant surgery can be electively scheduled to suit donor and recipient, and this resulted of better outcome, better survival transplant survival for this patient because of this preparation. And organs from living donor work much better than the deceased donor because, as we all know, most of transplant center where the living and the donor works, so they actually shorten their ischemic time, So this improved the graft survival to the recipient much better than deceased donor. Next. And then we talk about deceased donation or deceased transplant. This is a process where we give a deceased patient from the time of their death, they give an organ or tissue for purpose of transplantation. And this deceased patient, they can be a single organ donor or multiple organ donor, because when you die, you can use everything on your body. You've not even donated your kidney, you can give consideration to liver patient and heart lung patient, as well as some tissues like cornea, tissues like bones and heart valve as well. And it is possible when the blood circulation of the internal organs can be maintained until the time of the organ procurement. Thus, this common type of deceased donor are coming from brain dead patient. When we talk about brain dead patient, although they have declared dead, but they are still on oxygen ventilation, this keep maintain their organs to be used for transplant. And number three, most importantly to talk about deceased donor is dead donor rule, which means this patient, before they can become a donor, they must be confirmed as certified dead. And in brain dead patient, we have to follow our consensus, our rules to make sure that this patient actually has become brain dead before we can procure or we can take their organs. And then, as stated in Human Tissue Act 1974, consent for donation shall be obtained from next of kin of the deceased. And the donor pledger or a living patient, a living person who registers as a donor, we always remind them to inform their next of kin for their intention, because in the end of the day, their next of kin can decide to give the consent for donation or not. All right, next. And what is the benefit of deceased donation in compared to living transplant or donation? There is no risk to the donor. Okay, when we talk about living donation, there is some ethical concern and issue that some people actually ask about can we actually subject a person to do a surgery for transplant? But for deceased donor, there is no risk to the donor because patient are already died. And number two, it can benefit the need for other organs. And like I mentioned just now, heart, lung, and liver as well, and some other tissues. And number three, the benefit of this deceased donor is actually larger pool of donor. And because just to give some perspective, our country, motor vehicle accident, mortality due to motor vehicle accident every year is about 6,000 to 7,000 patients who died due to motor vehicle accident. And imagine if 10% of this mortality can become organ donor. So it has a larger pool of organ donor. And in fact, for the kidney donation, it gives 2 kidney to recipient in compare with the living patient. Okay, next. Now I will show you some statistics about the low numbers of deceased donor in Malaysia. And if you can see, for the last 10 to 11 years, our graph shows very fluctuating result in the organ donor, actual organ donor. In 2010, we have about 18 organ donor. Then we are fluctuating up and downs. Until 2015, we have the highest actual organ donor disease, which is 32 organ donor, which about 1 donor per million population. However, after 2015, we are still struggling, and we are now picking up in 2020. And despite pandemic COVID in 2020, NTRC and the team overall in the country managed to get 29 organ donor, which is actually quite proud for the situation happened during pandemic, that we managed to get a lot of organ donor during that time. However, last year we are somehow again still in the situation of pandemic. Therefore, our activity are very much suppressed. We only managed to get 7 organ donor. Next. Okay, this is the statistic from the International Registry Organ Donation and Transplant Activity. So this I want to show in 2015. At one time, we actually have more kidney transplant from deceased than a living. So this is quite achievement for a deceased transplant. If you can focus on the organ transplant, kidney, disease, and the living there, then we have about like 82 kidney transplant from the deceased, about 31 only from the living. Okay, next. However, in 2020, and I think subsequently after 2015, living transplant has started picking up, and more effort has been done by the living donation and transplant team. So, and there is a quality target or indicator that must achieve. And now we are in the situation where our living transplant for the kidney is more than deceased donation as well. And of course, the deceased donor also started to going down. Next. This is I think this is very, very small, but this actually to show you how we compare ourselves, Malaysia to be compared to the rest of the world. This is from International Registry Organ Donation as well, registry. And worldwide actual deceased donor in 2020, where actually Malaysia is about 0.9 donor per million population. If we can zoom the slides, there I can show you the location of the Malaysia, which is at the bottom of the ranking. All right. Okay. Next. Okay, this is to show you the worldwide living organ from the similar registry activity in 2020. Even both disease and the living transplant and donation is still, we are at the bottom in compare with other advanced country. And if you look at this graph or any other graph like this, you can see state like country like Spain, US at the highest ranking of the donation and transplant activity. Next. And this is to show the worldwide kidney transplant from deceased donor in 2020. And again, Malaysia ranking are very, very much below to become to the rest of the world. So yeah, I cannot see that much. It's about 1.28 donor per million population. All right. And next. Okay, this is a statistic to show you the numbers. This is the latest statistic in February 2022 from National Transplant Registry. This is donation. Numbers of organ donated from a deceased donor, and more people actually ask us which organ actually more people donate after deceased. So kidney donation is the highest numbers for the donation, about 670, and that's come for the rest of other organs. Okay. Next. Now we talk about our challenges. Not enough organ donor and less transplant, as we can see from the statistic. And of course, this gives rise to transplant commercialization. People are desperate. They go for overseas for transplant. This could give rise to illegal practice and give rise to human trafficking. There is a coercion for donation as well. And then number 3, our challenges of healthcare and society attitude towards donation and transplant. Next. What is our effort and strategy? We divided this effort and strategy to 2. First, the hospital or the healthcare strategy. We have to create clinical champion and dedicated team in disease organ donation. And this goes as well for living transplant. There should be a very trained personnel, medical personnel in doing the transplant, and more transplant center can be developed to cater for the demand. And number 2, improve healthcare professional towards the knowledge and attitude for organ donation and transplant, like also Dr. Rosna mentioned about nephrologists, education for nephrologists. This is also has to apply to others as well. And also number 3, create quality indicator in disease and living donation, which means to improve the donor detection at the hospital level. And for the society strategy, we have to continuous awareness program and promotion to the public, strengthening collaborative effort with government agency, NGOs, and medical society. And number 3, engagement, not just a physical campaign, we also go for media, also for the social media as well. Okay, next. I would like to show you some of our activity and photos of activity. This is how we empower healthcare for deceased donor. So we have to train them. We have to set a quality indicator to look for the brain dead donor in the hospital so that we can have organs, deceased organ to cater for the demands. Number 2. And next, sorry. And this is a public education and promotion. We go for religious body, we go for students, university, and we go for the public. We do a marathon, we do a run event for transplant. And this is the event for FK transplant in UiTM. Then we go for promotion as a whole, big event. Next. And this is a social media campaign. We have to utilize whatever platform that we have to actually spread the awareness and campaign. This is how we tackle on the social media campaign. Next. And some of the web bicara, web talk among of the healthcare expert in transplant and donation. And also testimony from the patient who receiving transplant and also patient who actually give the donation, the organ donation as well. Next. Okay, this is to conclude my presentation. Now we have seen a lot the previous presentation. I think after this, Prof also will explain the treatment. Now, organ transplant, organ donation, without the organ and tissue donor, there is no story, no hope, no transplant. But when there is an organ donor, life springs from death, sorrow turns to hope, and a terrible loss become a gift. And that's all.
Thank you very much, Dr. Hasdy. You can also visit the website of the Malaysian Society of Transplantation for more information on kidney health and explore how you can care for kidney patients. And also you can pledge to become a donor at the National Transplant Resource Centre, their website. You can help save a life by donating your organs and tissues today. All of you who pledge and sharing of this information on kidney health is important and it is most appreciated. However, it doesn't sound as simple because I think later on we'll talk to Dr. Hasdy about even though you pledge sometimes after death or in the event that a donor is actually willing to be a donor, family members can be an obstacle upon that time. So just moving on to Professor Lim before, in the interest of time, Professor Lim, over to you.
Yeah, thanks Mira for the introduction. So sorry for the technical glitch just now. So I'm ready. Can you hear me, Mira?
Loud and clearly.
Okay, thanks. All right, so good morning everyone. So I'm going to touch briefly on chronic kidney disease treatment in Malaysia. Next. So this is a simple outline of my lecture. Next. So I think Dr. Rosna have shown this before, but it's just to highlight that once a person suffered from chronic kidney disease, the disease will continue to progress over time until they reach end-stage kidney disease, or we call kidney failure. Right? Of course, when somebody reaches the stage of either stage 5 chronic kidney disease or we call end stage, then we have to actually discuss about renal replacement therapy. Next. So just a very simple on renal replacement therapy is actually a treatment to replace the normal blood filtering function of the kidney. As it's important to highlight that it's actually life-saving. Because if you think about it in other organ failure, for example, heart failure and liver failure, we do not actually have liver dialysis to sustain a patient's life. But in kidney, we actually have a treatment that is called dialysis that can actually sustain a patient's life and keep them healthy. And of course, the renal replacement therapy, the purpose is to replace the function of the kidney because the kidneys are not functioning. So it helps to clear the waste product from the body, it remove the extra water, it correct the abnormalities in terms of electrolytes as well as acidosis. Next. So when we talk about options of renal replacement therapy, this is something that we always talk to patients to tell them it's not only one, there are multiple. They can actually consider hemodialysis, what we call normally cuci darah, or peritoneal dialysis, cuci air, or kidney transplantation. And of course, nowadays, we have to actually consider palliative care if someone's we think are not suitable candidate for all this renal replacement therapy. Next. So I think it's important also for a patient to understand that when they make a choice, that is not the fixed one. It's always interchangeable. So some patients after on dialysis, hemodialysis for some years, if the condition has changed and we found it not suitable anymore, we can always change to peritoneal dialysis. So similarly, if someone started on with a peritoneal dialysis and he managed to get a donor, he can also go for kidney transplantation. Next. So again, I think palliative care is something that we have to take into consideration, as some patients after some years of dialysis, they exhausted their access, they have no suitable access anymore, then palliative care will be some important consideration. Next. So when we talk to patients about all these dialysis, sometimes it's a bit difficult for them to imagine how it is like. So we always like to describe to them so that they have a picture how it's going to be their routines if they choose certain option. For example, hemodialysis. Can you go back a little bit? Go back one? No. Yeah, this one. Yes. Okay. So if a patient chooses hemodialysis, then they have to imagine they have to go to a center to do the treatment 2 to 3 times a week, generally about 4-hour session. The treatment will be taken care by the nurses. They might experience some symptoms during the dialysis, such as cramps, giddiness, sometimes vomiting. And of course, when they go back, a lot of people, especially older person, they might actually take some time to recover from the dialysis. They feel tired, they have to sleep for a while. And of course, the family, besides financial, they have to make some arrangement to send them to the dialysis center. On the other hand, next, so if a patient chooses hemodialysis, then they will expect that this is actually in the home dialysis, where they will be staying at home to do the treatment. Of course, they can do it themselves or supported by the family members. Generally, they don't have much symptoms like hemodialysis during dialysis or after dialysis. Of course, they have to be more independent because most of the time they'll be at home doing the treatment, then only go to hospital for follow-up probably every 3 months. Next. So this is a scenario in Malaysia. I think Dr. Rosna touched about this a little bit. So generally, our ratio of hemodialysis to peritoneal dialysis is about 9:1. That means 90% of people doing hemodialysis and 10% doing peritoneal dialysis. Of course, looking at this kind of statistic, we cannot actually draw a simple conclusion and say, oh, look like hemodialysis is actually better, right? Because this is something to do with the country scenario as also government policy. So just take an example, like in Hong Kong, they have a very small area, so they don't have a lot of space to build a hemodialysis center. So government has to actually change their policy to encourage peritoneal dialysis. So in Hong Kong, the ratio is actually reversed. Their PD is about 85 to 90%, and hemodialysis is only 10%. So you can see that it changes with the different country scenario. Next. Okay, so this one, I think you have seen this statistic before. Just to highlight that we have, I think by now we probably have more than 50,000 of end-stage kidney disease patients in the country. But majority of them, as you can see, they are doing hemodialysis. Only a small percentage have the opportunity to do peritoneal dialysis as well as kidney transplantation. And of course, next. So if we put ourselves compared to the other countries in the world, then you can see that there are certain countries in the world having a very high incidence of treated end-stage kidney disease. For example, the States, right? So they belong to the red one, which is actually a very high incidence. And of course, Malaysia, we are in the middle, about 200 to 300 per million population. Of course, when we look at this kind of statistic, we can be very proud and say, oh yeah, we are doing a good job because we are providing a treatment to majority of patients having end-stage kidney disease. But on the other hand, we also have to bear in mind that this statistic also reminded us that we are having a lot of cases of end-stage kidney disease, which is not a good scenario. So as Dr. Rosna pointed out, we probably have to put more emphasis on primary prevention as well as secondary prevention to reduce this incident. Yeah. Next. Okay, of course, we said dialysis is good because it's life-saving, but there are a number of limitations. So as you can imagine from the description of the routines of a dialysis patient, there are a lot of restrictions in terms of their work as well as traveling that affect their quality of life. And of course, a huge socio-economic burden. They have to pay out of pocket. Some patients without the government support, they have to pay out of pocket. And of course, the longer they are on dialysis, there are more complications. But more importantly, the survival rate is actually very scary. If you look at this kind of a statistic, you look at short term by 1 year, they are not much of different compared to a transplant patient. They still have about 80% of survival rate after 1 year. But if you look at 5 years time, only less than 50% of them actually survive after they are on dialysis. So that highlighted a very important limitation of dialysis. Even though we said we have a good treatment compared to other organ failure in sustaining their life, but the survival is actually very poor in the long term. Next. So that's why we want to talk about kidney transplantation. I think kidney transplantation in the simple term is basically is a surgical procedure. We basically place a healthy kidney from either a living donor or deceased donor to a patient with kidney failure. So I think this graph basically highlights a very important fact that when we do a transplantation, we do not remove the diseased kidney and put them back into the original place. And this is actually what many of my students actually taught, they think that when we do transplantation, you have to take out the old kidney and put a new kidney there. So it's actually not true. If you look at this graph, we basically put it in the different place. And strictly speaking, a patient who is a kidney transplant recipient, essentially they have 3 kidneys, the 2 damaged one and the new kidney. Next. Of course, I think this one, Dr. Hasdy touched on that. Just put it into a simple term. Basically, we classify kidney transplantation based on the source of the donor. Right? So if the donor, a living donor, so we call it living versus deceased donor. And for living, they are related or unrelated, basically based on their genetic link. Yeah. So I think it's important to understand that in Malaysia, we do not actually say that we cannot do living unrelated transplantation. But there are many challenges because we have to submit the application to the 𝐊𝐃𝐃 committee, and the 𝐊𝐃𝐃 committee essentially will review and interview the recipient and the donor and make a decision. So based on our experience, it's not easy. Actually, you get the approval from the 𝐊𝐃𝐃 committee for a living unrelated transplantation. So our Malaysia scenario is definitely different from other countries like United States. Next. So this is just to give you an overview of the kidney transplant center in Malaysia. As you can see here, I think most of you will notice, majority of the centers are at Klang Valley. Right? So far we only have one outside Klang Valley, which is actually Mahkota Medical Center at Malacca doing kidney transplantation. And I think the second observation, you also will notice that there are a number of government-based hospitals doing kidney transplantation, namely Hospital Kuala Lumpur, Selayang, UMMC and UITM. For the meantime, there are 3 private centers conducting kidney transplantation. There is Prince Court Medical Center, Sunway and Mahkota. Of course, to me, personally, I'm actually glad to see that more centers coming up to do the kidney transplantation, basically because we have to give option to our patient. Right? And also we fully understand that the limitation of a government-based system to provide transplantation to all the patients in Malaysia. So if we have more centers, definitely patients have more opportunity and we shouldn't limit that option. Next. So this is some statistic that I don't like to show, but I have to show because this is just to highlight our issue. So one hand, we see a number of dialysis patients, new patients coming into dialysis every year, 8,000 plus a year. But on the other hand, we see we only have very small percentage of patients manage to do transplantation. Of course, 2018, we only have about 90. But I think 2020 probably was our best year where we have about 150 of a kidney transplant in whole Malaysia. But the number is still very small. Next, of course, putting ourselves into the world map, you can see that Malaysia, I actually highlighted to you because it's a very small writing, but we are actually at the very bottom. You can look at this because this one, they arranged to the proportion of a kidney transplant. So we can see we have only a small percentage of patients doing kidney transplantation, and our rate is about 3 per million population. So if you want to compare to our neighbor, for example, Singapore, they actually are doing probably about 10, 15 per million population. So if you take our population as about 33 million, so if it's 33 times 10, we have to do 300 a year, right, to meet that kind of expectation. So if you're talking about 15 per million population, we have to do 450. And now we are only doing 150 as the best performance, for 2020. So that basically tells us that we have a lot of things to do, a lot of effort to put in to actually improve this scenario. Next. So why as nephrologists, as clinicians, why we want to have more transplant? So the answer is very obvious. Because we have seen patients manage to come out from dialysis, be able to travel, having better quality of life. We have seen patients be able to recover from their infertility, manage to have baby and have a happy family. We have seen young patients manage to continue with their study and career and become a professional. And we have seen patients who are interested in sport, they can actually participate in transplant game, be good at their badminton. This is one of my patients who won some trophy during a transplant game. So these are the basically benefits that we have observed. And this is also, I would say, our main motivation, why we want to push for the transplantation in the country. Okay, next. So I think in short, I would like to use an analogy of a car, for transplantation. For the meantime, like transplant is like a BMW and Mercedes, which is good, and but only a small percentage of patients be able to enjoy it, own it. But we hope we can make kidney transplantation like a Toyota or Honda, which are also equally good, but cost effective and more accessible to more people. So with that, thank you very much for your attention.
Thank you very much, Professor Lim. Just moving on in just a short while, but it's very interesting insights about kidney transplantation. And moving on to our panel discussion, we will discuss the current issues and suggested solutions for chronic kidney disease. I've got lots of questions for our panelists. If I can invite them back on, Dr. Rosnawati, Associate Professor Dr. Lim, and Dr. Hasdy. And you, the members of the media, we'd like to invite you to raise your questions via the chat feature. State your name and publication as you raise the questions to any of our speakers, and we'll be most happy to answer them for you. So I'm going to kickstart this conversation after presentations. I'm going to start with Dr. Rosnawati. Dr. Rosnawati, from your presentation, you can tell that non-communicable diseases is a huge problem in Malaysia. We know that, right? You've shown us the statistics, diabetes, hypertension, and obesity in particular. And we're seeing younger and younger people with NCDs in Malaysia. So if that's the case, and if that has a huge impact on kidney, we're going to see tons more people with chronic kidney disease soon. If not now, it's going to come and bite us in the back. But what does survival look like if we continue in this trajectory for the younger generation?
Sorry, Mira. I need you to clarify. What are you referring to in terms of survival?
Sure. So given the situation we're in right now, and we have more and more people depending on hemodialysis, right? We have majority. We know only 6% go for transplantation, and it is many limitations along the way. But if we don't do something about it now, what does survival look like for our future generation who more and more have non-communicable diseases? It's going to be a strain on our system. I mean, we can't cope in terms of hemodialysis. What does a possible solution look like for you?
As I mentioned just now, I think our focus should be on the prevention, right? Prevention, I think, has to play a major role in order for us to reduce that number. Number one is, if you look at the Malaysian Health Ministry plan on the ACT kit, Prof. Sukun is active in the ACT kit, looking at prevention, not only prevention of CKD, but prevention of all the metabolic diseases, including obesity, hypertension, and diabetes. And this is where we should focus our effort, looking at if we allow the obesity pandemic to continue, we're just going to see the number going up. I've already shown you the economic burdens where the money that we spend to treat end-stage renal disease has gone up by 94% within a short period of 6 years. I'm not sure how it's going to be looking like in 10 years' time. And the current model of funding for dialysis is probably won't be sustainable. So many more patients will probably not be able to get those treatment, to get dialysis. We will probably go back to 30 years ago where if you don't go for transplant, you die because the funding is probably not sustainable. And the reason why we need to focus much more on transplant is because we know transplant probably is expensive in the first year, but would be much cheaper in the long run. Right, and that study have been shown across the world where transplant is actually more cost saving. Even the high risk, the transplantation that is considered high risk, where more medications are required.
I am very concerned because I can't see NCDs going down soon. You know, so much needs to be done. I think as a country, we need to be cruel, to be kind, in terms of very aggressive ways in managing NCDs in the country. And it goes back to our diet and our life, very much our lifestyle, isn't it? It is, you know, chronic kidney disease is a silent killer. A lot of us don't know we have it. As you said, only 5% of the population knows that they have it. So what do you suggest people do to sort of pick it up early? Because if you pick it up in the early stages, your prognosis looks a lot better. Am I correct?
That's right. So go for early screening, especially if you are at risk, right? I mentioned the group who are at risk, those patients with diabetes, those patients with hypertension, obesity. Go for early screening. And early screening is simple and not very expensive. You only need to have a urine test to detect the presence of protein in your urine. Go for blood pressure check so that you can detect if you have early hypertension. Go for blood testing to check your kidney function. It's a simple one-time of blood test. And go to check your sugar regularly, at least once a year, right? And while you don't yet have all this non-communicable disease, go and practice healthy lifestyle, exercise, keep your body weight in the healthy range, don't smoke, and eat healthy diet, I guess.
Yes.
Right?
Half of us are either overweight or obese in this country. That's a lot of us. That's an indication of what's going to happen in the future, right? But yeah, I suppose a simple test at this stage, while we get our act together with diet and lifestyle, go and get yourself checked so at least you will be able to pick it up early, right? We have a question from the media. What are the key challenges faced by the caregivers in terms of dialysis, and how can they overcome these challenges? Who wants to take Dr. Lim, Professor Lim?
Just probably a brief one. Of course, when we talk about key challenges, we probably have to, I think this is not specific to dialysis. We are talking about a care of a chronic disease. So you can imagine you have a family member who's having chronic disease in the family. Definitely it affects the whole family in terms of financial. And dialysis is a very expensive treatment. And many of the patients, they don't have insurance because they have chronic disease, diabetes from a young age. They can't buy insurance, so they have to pay out of pocket. So financial is definitely one. And of course, when a family member is having a chronic disease like end-stage kidney disease, the family have to make a lot of adjustment in their family life in order to support their family members. For example, sending them to the dialysis center or even performing the dialysis procedure at home. So a lot of adjustment need to be done. And I have seen like a son or daughter who actually give up their job just to support their parents because of dialysis. So this is actually one impact definitely on family. Of course, we look at the broader picture, that would be our social and the whole country. Because if we are having a lot of these young people who actually suffer from this end-stage kidney disease, essentially it means reduced in productivity, and we actually lost a lot of young talent, maybe because of this chronic disease. You know, I have actually professors who actually suffer from chronic kidney disease. They are brilliant academicians, but they can't actually contribute because of chronic disease, and they die young because of this disease. So I think the impact is definitely huge, from personal to family to actually social and also our country. So that is definitely something we have to actually look into to actually minimize this. Yeah.
Okay. So moving on to my next question, Dr. Hasdy, you showed us a diagram just now. Malaysia is so low in the ranking in terms of the number of donors, am I correct? But if I'm not mistaken, if my eyes isn't deceiving me, right on top was Turkey, am I correct? Was Turkey right on the top? What has Turkey done so well to facilitate the number of kidney or organ donors? And you know, Dr. Lim spoke about Singapore, but Singapore has a opt-out program. Malaysia has an opt-in program when it comes to organ donation. Is that something we should go towards? And what has Turkey done? Let's start with that one.
Thank you, Mira. Okay. Well, we look at in comparison with other country, Malaysia is pretty much not very, very low. And when you spoke about Turkey, when we look at Turkey is a country where the donation, they are doing more living transplant in compare for disease transplant actually. Okay, but the way that they actually, they have a good team. They have a good team. They have a more and collaborative effort together of the transplant center, whether it is from government and non-government or university. And this is a teamwork that takes them to overcome the challenge of doing a transplant. So if we talk about the way they in terms of the legal aspect, or of course their system is actually similar to us. They are also practicing the opting in. They still need a consent for the transplant or donation. This is donation as well. And this is one of the thing that we can see from Turkey, especially when we see their collaboration effort in between of every centers who's doing the transplant, the university, the government, the private center, and even they when they do the training for the transplant and donation training, they will contact everyone to be included in doing the service or education as well. So something that in our country need to explore the collaboration effort together in between of our transplant center, as well as more effort responsibility that should be taken up for everyone to make this service or successful actually.
Yeah, okay. Dr. Lim, you mentioned the number of hospitals in Malaysia that can perform kidney transplant surgeries, which is not a lot in comparison. So my fear is if we do start having higher organ donation rates, then we may not have enough centers who can do kidney transplantations. So the question from 𝐊𝐈𝐃𝐍𝐄 is, what happens if a patient lives in a state where there is no specialist for transplant surgery? What happens then?
Yeah, just a quick one. Generally, we have a well-defined referral system where the nephrologist taking care of the patients, they can actually refer to the transplant center. So it can be from a private hospital referring to MOH or even MOE hospital. There can be, of course, those in the government hospital. Most of the time, they will actually refer to the transplant center at Klang Valley. So for the meantime, it's a well-defined referral system. All the nephrologists actually know about it, how to refer, and we are all friends. So they can just, we are just a call away. So they can just give her a call and say, we have a patient interested in transplantation, then we can set an appointment to see them. Yeah.
Okay. What happens, would you like to go through with us, when do you start having this conversation with a patient about a kidney transplant? Do you wait for stage 5 or do you start that conversation much earlier?
Yeah, of course, just now I didn't actually touch on that, but talking about timing of transplantation, there are two, right? One is called preemptive transplantation, where the patient has yet to reach a dialysis stage. We can actually do the transplant and actually cure the patient from kidney failure. That is actually the best, right? And of course, most of the patients in Malaysia, they will go through dialysis for some time, then only they explore transplantation. So they can be either before they reach a dialysis stage or after they are on dialysis. So of course, in our setting, most of the time we will start talking to patients about kidney transplantation or renal replacement therapy as a general when they reach stage 4. But of course, different patients take different time and to think about that. Even though you talk to them early, sometimes they might think that okay, it's not yet. We don't want to talk about that. So different patients have different motivation. Some patients are very motivated. They started the preparation very early. But generally, for us, we will start talking when they reach stage 4. It means when the kidney function actually drop less than 30%. We will start telling them that one day they will have to face this scenario and what are their options. I think it's important sometimes to introduce the idea early so that the patient will actually take some time to actually discuss with the family and explore the options.
Okay, and are family members more open? Because it can be tough conversation.
Definitely. So it's actually very interesting to see a different family dynamic. Some the family are very motivated. They come forward. They say they want you to be the donor. We also have patients who actually tell us that very difficult to initiate this conversation because they do not want to appear that they are actually wanting the kidneys from their family members. So it very much depends on the family dynamic. Of course, for us as a clinician, what our role is basically to facilitate and to actually assist them. So if they need further explanation, usually we'll call the family to come in so that they can ask whatever question to clear their concern and doubt before they make decision. I think it's important. We have to always tell them to say that when you come forward to understand more, it does not mean that this is a commitment for you to donate. It's always good to understand first, and then you can make a decision and discuss later. Yeah.
Sure. We'll come back and discuss why people are hesitant. And of course, being a donor, there are risks involved to the donor as well as the recipient. But before that, Dr. Rosnawati, I mean, we can have as many centers, but do we have enough people who can actually carry out a kidney transplant in Malaysia?
That is a $1 million question, Mira.
They're all going to land up in Professor Lim's office and he's not going to be able to cope. Yeah.
Yes, we recognize the issues that we don't have adequate numbers of transplant professionals. But certainly Ministry of Health are looking at, number one, retaining our professionals in the Ministry of Health, which is not an easy job, as a lot of issue regarding promotion, so on and so forth. Transplant, unfortunately, is not recognized as a critical services in comparison to cardiovascular. So promotion is an issue. And I think that's one of the reasons why many people leave the service, right? And transplant is not really an easy job because it can happen at any time of the day. We are practically on call 365 days a year. We are expected to answer call even when we are not on call, basically. So it's not easy. I think it requires a lot of commitment. And somehow I think ministry, we have had several discussions at ministry level to actually look into making a transplant profession more attractive to healthcare workers. That's number one. And number two is, and ministry is planning for further training for not only nephrologists, also looking at surgeons, not just kidney surgeons, also liver surgeon, heart surgeon, lung surgeons, to cater for the needs of other organs, other end-stage organ failure as well, right? Plus the supporting services. Mira is muted. Mira, you are muted.
Thank you. Then I need to ask both of you, when was the last time you went on holiday? It's probably a very long time ago. Dr. Hasdy, you mentioned something about 𝐊𝐃𝐃, getting approval from 𝐊𝐃𝐃 as a committee for living donors. Now, in my mind, after the presentations, it would feel like living donors is our better hope at the moment compared to deceased organ donations, because till the awareness and the barriers actually come down for that, living donors may be the better option for a kidney transplant. But getting the approval from 𝐊𝐃𝐃, is that a bottleneck? Is that, how urgent do these approvals need to be before somebody can actually be a living donor?
All right, thank you, Mira. Okay, for the approval of the unrelated transplant, as mentioned in previous presentation, Prof has mentioned also, this process sometimes are very, very tight. So the reason actually the government created this policy for unrelated transplant is because we are afraid of the transplant commercialism. As I mentioned, this is could resulted from unregulated transplant activity. So this is where the government see the needs to create this policy for the unrelated living organ transplant. So yes, I can agree that sometimes the process very, very tight actually, because we need to ensure that the application submitted to us for the transplant are not due to some coercion. There is a due to monetary, some commercialization, organ selling, and those things that we should know that is a very dangerous to the service. As we know, Malaysia also upheld the Declaration of Istanbul, where we actually prohibit the activity of commercialization as well as this transplant, unethical transplant. So before they can go to the special committee of 𝐊𝐃𝐃 committee, which actually this committee was dilantik oleh Kementerian Kesihatan lah. They will have the donor and the recipient has to go for special evaluation or assessment by the independent donor advocate assessment. This pelantikan or these doctors or medical professional will assess and evaluate the transplant, the donor and recipient sites, and to see whether there is elements of like I mentioned just now, the elements of organ selling, organ buying, and is the donor actually aware that this procedure are actually safe for them. So in my experience, most of the application, like when we put up this policy, most of the application is coming from foreign donor, because the foreign donor are considered as well as the unrelated transplant. And there is some application from which unrelated, but in Malaysian donor. But definitely the government still assists to ensure that this transplant is doable. It's just that we have to be very, very careful. Okay, we don't want to be accused for something that we, like I mentioned just now, because even so, Malaysia has been attacked or accused for so many things before in regards of transplant commercialization. There is some news out of nowhere was saying there is an organ broker of selling organs here and there, and illegal donation or something. But of course, when we investigate those accusations, that is wrong. So we are still keeping this policy to ensure the safety or the ethical aspect of the transplant are maintained. But at the same time, the government still give this opportunity to make sure the living transplant can happen. It's not necessarily that we have to reject every application, but we have to just be very, very careful. That's
Sure.
all.
Before I move on to the question on News Hub, and I suppose News Hub Asia, and I will start with the risks to the recipient of the organ or of the kidney, Professor Lim, and of course the biggest risk, of course, is the failed kidney transplant, meaning rejection, for an example. Would you like to go through that with us? Professor Lim, can you hear me? Professor Lim, can you hear me? Can you hear me?
The connection not very good.
Okay.
Yeah.
Can you hear me? Yeah, go ahead. My question to you is the risk to the recipient of an organ transplant, of a kidney transplant, and moving on to the News Hub Asia question, what are the risks of a failed kidney transplant?
Okay, so the question probably talking about someone have gone through kidney transplantation, how high is the risk that the kidney might fail, right?
That's right.
So I think with the advancement of the anti-rejection medicine and immunosuppressants, generally rejection, of course, the issue is still there, but the risk is actually very low. So in a very well managed kind of a scenario where patient can follow our instruction regularly, take medicine and all this thing, generally the rejection rate can be 5 to 10%, depending on the risk that we are, the rejection rate that we are looking at individual. So generally it's very low. I would say it's only 5 to 10%. Yeah. So of course in certain center where they are doing so-called high-risk cases, where patient itself have a high risk of rejection, definitely the risk of rejection might be a little bit higher, but generally the risk of rejection is low.
Okay, sure. We have another question. Are donors and recipients of kidney transplants eligible to donate or receive if they were once a COVID patient?
Rosna, you want to take this?
Oh, yes, definitely. The simple answer to that is yes. But of course, depending on the COVID category, we will tend to reevaluate the situation. If they have category 4 and 5, we want to make sure that anesthetic safety, right? Because everybody have to go through anesthesia. Whatever assessment that they have undergone before have to be reevaluated. And we also obtain respiratory physicians' input to make sure donor and recipient surgery is safe. I just want to add on to the question about graft survival that was posted on earlier. The survival of the graft very much depends on the donor type. So if you have received a kidney from a living donor, your 1-year graft survival is about 98%. This is based on our registry data 2016. So 98% of graft still survive at 1 year, 96% at 5 years, and 92% at 10 years. So the outcome of living donation is very good. However, the outcome of deceased donation is not as good, with only 92% survive at 1 year, 85% survive at 5 years, and about 70% at 10 years. So that's the major impact of donor types.
Okay, all right. And what are the risks to the donor, Professor Lim?
Okay, so when we talk about risk to donor, we have to look at short-term as well as long-term. Right, so short-term is related to operations. So nowadays, the standard of care for donor surgery is actually laparoscopic surgery, which we call a minimally invasive surgery. So I would like to probably equate this kind of a risk in terms of donor surgery to something like a medium type of surgery. It's not as high risk as a bypass. Of course, it's not as low risk as an appendectomy. Right, so it's somewhere in between. So people actually look at talking about, right, it's almost the same risk that you removing a gallbladder, cholecystectomy, and that kind of risk. So this is a short-term kind of risk. Of course, long-term, we have to actually educate our donor to say that that is actually a small risk of them, developing high blood pressure, having protein in the urine, and also there is also a very small risk where their own kidney might fail, and they themselves might end up with end-stage kidney disease.
So they are, if I'm correct, they are considered patients of kidney disease, am I correct? Or in the stages of 1 to 5 if they are a donor? Is that true?
Not really, but we are saying that because that very much depends on our initial pre-transplant assessment. And if you take on a patient who is actually very healthy and they have a healthy kidney before the donation, the risk is actually lower. If certain centers are basically taking a high-risk donor, whereby their kidney in the first place is already not in a very good condition, and you decide to actually take them, of course, the risk will be higher. So, but generally for kidney donor, the risk of them getting into kidney failure as well as ended up problem is actually low. Right? But of course, age at donation is very important as well.
Sure.
So if you're talking about a young donor, then of course we have to make them understand the lifetime risk is something that they have to consider. Because if they donate at age of 20, if they live until age of 70, that means they have to live with one kidney for 50 years. So the risk is definitely higher as compared to someone who donate at age of 50 and they live until age of 70. Right?
Okay.
So that kind of risk, lifetime risk is something important to take into consideration.
Sure. Question from Good Health. After kidney transplants, what does life look like for both donor and recipient?
Rosna?
Okay, so basically both donor and recipient more or less can go back to normal life, but bearing in mind the kidney transplant is not real a cure. They still need to do to make a lot of effort to look after these new kidneys. So the adherence to immunosuppressant therapy is mandatory. And of course, whatever risk factors I mentioned earlier about progression to end-stage kidney failure, again, healthy diet, low salt, prevent obesity, a good blood pressure control, and if they develop proteinuria, there are medications they have to take to make sure this kidney lasts as long as possible. For donors, similar things, prevent from being fat, don't go back to smoking if they have smoked before, healthy lifestyle, healthy eating, exercising, and come back for follow-up. They are supposed to be on lifelong follow-up. This is for us, doctors, to evaluate whether they develop blood pressure, whether they develop any protein in the urine. If they ended up develop diabetes, we want to treat that early. We want to manage the diabetes well. And you know how we are, whenever we see doctors give us reminders, don't gain weight. We sort of go home and exercise. When we don't see doctors a long time, we don't do anything, right? That's why those kind of annual or biannual evaluations is very important for the donors.
Okay,
as
so
well.
you will see your nephrologist for the rest of your life, really. I mean, to keep an eye on
Yes,
things, right? For both donor and recipient, or just the recipient? For
both donor
Okay.
and recipient. Yeah.
Sure. Next question. Are there any government subsidies or incentives for the patients who opt for kidney transplant?
Okay, and they are actually, for the donors, basically their admission and their surgery are free of charge, right? They're not charged at all if that's being done in public hospital, right? Those living donors actually receive a donor card where they are entitled for free medical treatment for life. If they actually doing the transplant in public hospital at this moment. For recipient, basically the public hospital charges is very small, and they receive lifelong immunosuppression for free. For those patients who actually consider did their transplant in a private hospital, government still give them one immunosuppression for free. The other one, unfortunately, is not covered at the moment. So basically, they are on two expensive immunosuppression. One is provided for free. The other one is not. Unfortunately, for donors in the private side, their operation is not yet covered by insurance, whereas the recipient is covered by insurance.
Okay. So
Yeah.
earlier on, sorry, carry on. Please add
maybe
on.
I would just add on something because I'm actually from Ministry of Education. It's just to highlight that for Ministry of Education patients, there's a slight difference with Ministry of Health. So as Rosna mentioned, for recipient, essentially they don't actually have to pay much for their transplantation. They get subsidy, essentially almost like free medication after transplantation. But for Ministry of Education, university hospital patients, essentially they have to pay. They have to pay for their operation. They have to pay for their medication after transplantation, of course, with a certain subsidy. Yeah, and it's they are paying probably about 1/3 of the cost. Yeah, so this is
Okay.
something to do with a different budget allocation from different ministry. And this is also something that we are actually working on, trying to actually make it equal, because for all Malaysians. So this is something that we are trying very hard to convince the government that all are Malaysians, so all are government hospital. So if they are coming whether to Ministry of Health or University Hospital, they should be treated the same.
Yeah, totally agree with you. I only realized a couple of years ago that there was a difference, and definitely your funding would be different, right? Education goes to education, not so much for health on your end. Earlier on, Dr. Rosnawati, you spoke about kidney disease associated with the aging, right? But there's a question on, does this affect younger children in Malaysia, and do we have statistics for it?
Unfortunately, the answer to that is yes, it does affect younger children. If I'm not mistaken, the last statistic that I'm aware of, there are about 700 children are waiting for a kidney in Malaysia right now. Unfortunately, the number of transplant performed in children is not very high. It's very much relied on living donor, meaning their parents or even grandparents. The number of deceased organ donors that is allocated to children below the age of 18 is very limited, because basically there's not many people had a brain death at that age, right? We probably perform about 2 transplant a year for pediatric age group from deceased donor.
Okay, fair enough.
The rest are living donors. Yeah.
Sure. And can you donate to a child? Can an adult donate to a child? Is that even possible?
Yes.
You can.
Yes, it can. Yeah, but of course, it also depends on the child's body weight. This is basically the comfort of the surgeon performing the surgery, but it can be done.
Okay, I need to get this out of my system very quickly, Professor Lim. Why does one have 3 kidneys? Why don't you just take off the bad one? I
Yeah,
just need to
this is
understand this.
yeah, this is definitely a question my student always ask me. You know, why don't you just remove the damaged kidney and put it back into the original location? So essentially, removing a kidney is actually another big surgery. Right. So we don't actually want to do like two big surgery at the same time. So if the damaged kidneys are not causing problem, not causing infection, not having a growth or anything, then generally we just leave it there. It doesn't disturb, we don't disturb it also.
Okay,
right?
but
So
what does it do? It just sits there and that's it.
Yeah, it's not functioning, so it doesn't cause you any problem. So we don't really have to actually remove it unless there are certain indication like infection. Yeah.
Sure. So I'm just going to do one round very quickly. If you have something to leave us with on kidney health for all, I'm going to start with Dr. Hasdy. Would you like to leave us with a message?
Well, I would like to emphasize the preventive advice from Dr. Rosna just now. It's not just everyone should be taking care of your health, not to become the chronic disease patients. As well as if you want to become organ donor someday, you must take care of your health, you know, because you want to, you have to register to become organ donor and you want to ensure that your organ will be suitable for use of transplant later on. That's my takes.
Sure. Professor Lim?
Yeah, I think if you look back into the theme this year, if we're talking about kidney health, of course, today we talk about a lot of our disease, right? So the best thing that we want to have is we don't have kidney disease. Of course, we know that is almost impossible, but we should actually try our very best to emphasize to public on the importance of primary and secondary prevention. Second prevention is equally important. It has happened, but it's never too late to actually intervene so that we can actually preserve the function as long as possible. And this is something I often notice certain public misunderstood, because we always emphasize that chronic kidney disease is not reversible. So they thought that once they have the disease, it's gone, no hope. It's actually not true, because if you detect it early, you manage to treat early, we are still able to prevent it going to kidney failure. So secondary prevention is equally important. Yeah.
Sure. So hence, don't get to stage 5 is what you're saying. Don't get there. You really don't want to get there. Or if all else fails. Professor Rosnawati?
Again, similar messages. I think this has to be repeated again and again because it is so important. We don't want to see the number reaching 120,000 dialysis patients in the year 2040. We need to flatten the curve. Primary prevention, secondary prevention. As Prof. Sukun, if you are diagnosed at stage 1, we want you to stay at stage 1. If you are diagnosed at stage 2, we want you to continue at stage 2. And reiterate again what Dr. Hasdy says, keep your kidney healthy so that once it's time for us to leave this world, we have healthy kidneys to donate to others.
Thank you very much, all three of you. That was Dr. Rosnawati Yahya, Associate Professor Dr. Lim Sukun, and Dr. Hasdy Haron. And thank you all members of the media, our respected guests, for this wonderful discussion. It was informative, very beneficial session for us to ponder upon, and a good reminder to all of us to live a healthy lifestyle and to continue to take care of your kidneys. With that, thank you very much and have a good day.